Good afternoon, everyone. My name is Shannon Kupka. I'm a project manager working with the nursing home cohort from Health Insight, New Mexico, and I'd like to welcome you to our half-hour Hot Topics series. These webinars are designed to provide you great ideas on antipsychotic reduction strategies in a 30-minute time frame to accommodate your busy schedules. They are brought to you by your statewide Partnership to Improve Dementia Care Work Group and sponsored by the New Mexico Department of Health, New Mexico Healthcare Association, and Health Insight. We are very excited about today's presenter. Dr. Gerald Russell is a clinical neuropsychologist. He is president of medical staff, division director of the Adult Psychiatric Division, and Center for Adolescent Relationship Exploration, clinical director at the New Mexico Behavioral Health Institute. Dr. Russell is an associate professor of clinical psychology and neuropsychology at New Mexico Highlands University, and is clinical neuropsychologist, CEO, and president of his private practice, High Plains Neuropsychology Associates, PC. His areas of clinical specialty include neuropsychology, learning disability, workman's compensation, disability, and psychological testing, and he has extensive experience with children, adolescents, adults, and geriatric populations. As director of the Adult Psychiatric Division at NMBHI, Dr. Russell assures the delivery of quality health services to adults with acute and chronic mental illness. I will now turn things over to Dr. Russell.
All right, let's go ahead and move to that first slide after that wonderful introduction. One of the things I always talk to people about is the idea between normal aging and what we view as dementia. In normal processes, as we age, and unfortunately starting as early as the ages in mid-40s, we start to develop some degree of memory loss. It's actually called age-appropriate memory loss, or AAML. Approximately 10% of the population over 70 have significant memory loss, and of those, at least 50% will have dementia attributed to Alzheimer's. So what I'm going to do today is a brief review of Alzheimer's and then talk about other dementias that you might see in the nursing home or long-term care setting. Go to the next slide, please. So, aging and dementia and IQ. As we age, we have two kinds of intelligence that we should always be aware of. Crystallized intelligence is what you know. It's your body of knowledge. It's what you've learned. That doesn't change much with aging. It's still in there. Fluid intelligence, which is the ability to think quick on your feet, think outside the box, to adapt to new situations. That's the one that starts to narrow with aging. When we talk about decline in aging, we're talking about three specific areas. Processing speed, which you'll often hear about, is essentially mental quickness. How quickly do you understand something? How quickly can you make a decision? The second area is abstract and complex problem-solving style. So this is where we see individuals becoming more concrete, having difficulty with complex problems where they can only follow part of it. And then, of course, the hallmark of this would be issues with both memory, accessing memory, as well as new learning, or the ability to form new memories. Next slide, please. So, in essence, as you age, you get slower at what you do. You get more concrete, and you begin to have more problems with your memory. But I want to stress again, this happens to everyone. We all get a little bit slower, a little bit more concrete, more problems with memory. But, next slide, there's a difference between normal aging and what we call dementia. The old term for people with severe memory deficits was mild cognitive impairment. These were people who had intact cognitive functioning, but they had almost amnestic memory ability. You'll see now, especially when they're diagnosed by a psychiatrist or psychologist, and sometimes a medical doctor, the new terminology for dementia is mild neurocognitive disorder and major neurocognitive disorder, which is analogous to mild dementia and major dementia. Next slide. Now, dementia, what we're talking about in dementia is impairment in at least three of the following areas: memory, complex attention, language, whether it's receptive or expressive, executive functions, and executive functions are reasoning, judgment, planning, sequencing, all that stuff. Perceptual motor, they start to have difficulty picking up things, they start dropping things. Social cognitive, they're no longer quite adept at recognizing social cues. And lastly, the ability to care for self or both the basic and instrumental activities of daily living. Now, I should say that to give someone a diagnosis of dementia, all of these issues must not occur exclusively during a delirium, when a person has an abrupt mental status change. Let's go to the next slide, please. Now, a delirium is a medical term used to describe an acute and relatively sudden decline in attention, focus, perception, and cognition. Usually develops over hours to days. It is commonly associated with a disturbance of consciousness, and usually it fluctuates during its course. Sometimes they're clear, sometimes they're not. Next slide, please. In the acute hospital setting, a delirium is the most common disorder affecting adults. It affects almost 20% of all hospitalized adults, and 30 to 40% of elderly hospitalized patients need to be assessed for it. So when you have someone who has a status change, you always want to check for things such as infection, a UTI, a pneumonia, something like that. Impaction. It happens with the elderly who especially have been under anesthesia, especially if the operation ran long. These are some of the things that might cause a delirium. So again, what we're saying is that when someone comes to you, especially when it's something new, we should always rule out that it's not a delirium. Next slide. Now, there are three broad categories of dementias that we should be aware of. Cortical dementias are dementias that affect primarily the gray matter or the cortex or the outside of your brain. Subcortical dementias affect primarily the white matter and midbrain structures, and a mixed dementia is both cortical and subcortical. Based on where the dementia is occurring, we are able to predict with some degree of certainty what kind of behaviors we might see, as well as how they will respond to treatment and or medication. Next slide. The cortical dementias include Alzheimer's. It includes alcohol-induced persisting dementia. It includes frontotemporal dementia. And it's also the chronic traumatic encephalopathy. This is the diagnosis that used to be known as Boxer's dementia or dementia pugilistica. This is the dementia that you get when you're exposed to repeated head trauma, blows to the head, or overpressure, as we see in returning veterans from the wars overseas. Next slide. The subcortical dementias are dementias that start in the middle of the brain and sort of proceed from there. So this is dementia due to Huntington's, Parkinson's, syphilis or neurosyphilis. This is dementia due to a subdural hematoma or a deep brain bleed. This is also the AIDS dementia complex because AIDS dementia and the encephalopathy unfortunately really like to eat away white matter in the brain. And this is the area of the pseudodementias, which are associated with people who are severely clinically depressed or people with severe bipolar disorder. It is an imbalance of the neurotransmitters in the part of the brain that leads to problems as we see in those with dementia. Next slide. The mixed dementias are the multi-infarct dementias. This is someone who's had more than one stroke. Lewy body dementia and vascular dementias, and the reason that's in there twice, by the way, is if your first stroke is a deep brain stroke and it goes to the cortex, such as your middle cerebral artery, that would be the cause. Next slide. Now, Alzheimer's, the most common form of dementia. It is the big bugaboo. Alzheimer's usually starts with subtle memory loss. followed by gradually progressing cognitive decline over several years, which tends to increase in rapidity as it goes along. Next slide. This is a slide I often give to people who come to me and think that they might have Alzheimer's. I talk about the difference between normal aging and early Alzheimer's. Normal aging is you have trouble finding your car keys. Early Alzheimer's is you put important items in odd places. So this would be your keys in the freezer. Normal, search for casual names and words. It's on the tip of your tongue. Alzheimer's, you forget names of family. You forget the names of common objects. If you forget the name of something or someone, you also don't usually, unfortunately, oftentimes forget that you forgot in the first place. With normal aging, you forget conversational details. You might have trouble finding a recipe. You might forget to write down a check now and then. You might cancel a date with a friend, or you might make an occasional wrong turn when driving. So that's all what we consider within the normal range, as opposed to forgetting entire conversations, not being able to follow a well-known recipe, no longer can manage a checkbook, and there's the withdrawal from usual interest. This is the period where people start to sort of step back, and they get lost in familiar places. If you change the furniture in the room of someone with Alzheimer's and you take them into the room, they may not recognize it as their room. Next slide, please. Now, frontotemporal dementia, this one says frontotemporal lobar degeneration. There are a whole lot of terms for these. This is when the frontal lobe and the temporal lobe in your brain are the first areas that are affected. This tends to be the gray matter on the outside of your brain, and this is where essentially the front of your brain starts to recede back. Next slide. In the over 65 age group, frontotemporal lobar degeneration is the fourth most common cause of dementia after Alzheimer's, Lewy bodies, and vascular dementia. In the below 65 age group, it is the second most common cause after Alzheimer's disease. This is a dementia that occurs early, in your 50s. And here you see where I've said right versus left. If you have left frontotemporal dementia, you tend to withdraw. You have what we almost call a pseudo-depression. You sit quietly. You don't want to do anything. Right-sided frontotemporal dementia, however, are people who lose their inhibitions. This is the person who may start shoplifting. This is the person who may start dressing inappropriately. This is the person who will blurt out things without thinking about it. I think you can guess which frontotemporal dementia is the one that oftentimes gets sent to the nursing home or long-term care facility first. Next slide. Now, CTE, or dementia pugilistica, is the due to one significant head trauma or repeated blows to the head. Can develop over a period of years. It can develop instantaneously. It tends to result in irritability, irritation, acting out, especially if the right side of the brain is more involved. Again, I think we should start to recognize that right-sided brain damage, for most of us, 99% of us, is going to lead to, unfortunately, too often, lead to acting out behaviors. Next slide. Now, subcortical dementias, and by the way, I am just giving you a smorgasbord. There are common features in dementia with Huntington's, dementias with dementia due to Parkinson's. There's slowed cognition, thinking kind of slows down. There's motor dysfunction. And there's a triad of symptoms is mood disturbance, motor disturbance, cognitive disturbance. And what's interesting is oftentimes, especially in Huntington's, it's the mood disturbance that precedes all of the other features. Next slide. Vascular dementia, multi-infarct dementia, second most common cause of dementia after Alzheimer's in the elderly, and this is 65 or older. Here, what you're talking about is middle versus anterior versus posterior, because it tends to go with the grouping of the main artery groups in your brain. Obviously, with frontal damage, the anterior cerebral artery, you're going to see things with decision-making, with being able to start oneself. With middle cerebral artery, you're talking about memory deficits, language deficits. With the posterior cerebral artery, you're talking about movement disorders, especially if the cerebellum is involved. And again, right versus left is also important. Left-sided middle cerebral artery damage leads to language disturbance, the aphasias. Right-sided, unfortunately, can lead to difficulty recognizing people, getting lost, with the unfortunate side effect that, remember, this is the side that inhibits most of us. Next slide, please. Now, Lewy body dementia is an interesting one. This is a dementia that is an aggregate of protein that develops inside the nerve cells. Your cells are no longer able to clean themselves out. Symptoms that can occur include cognitive impairment, neurological signs, sleep disorder, and eventually autonomic failure. And autonomic failure is when your brain no longer controls heart rate, respiration, and things like that. Cognitive impairment is the presenting feature of Lewy body disorder in most cases. This is a person who fluctuates. They're clear one moment, they're not clear. They have problems with attention, they have problems with alertness, they have problems with complex thinking. Psychological manifestations of those with Lewy body dementia are delusions, false beliefs, or wrong judgments, held to be true even if you show them that it's not. This is where they develop visual hallucination. They have a strong subjective perception of an imaginary event or an object, and oftentimes the visual hallucinations are animals or something in nature, just that just don't sort of jive with the environment. You can see apathy, especially if it's left-sided damage. You see anxiety, you see apprehension, and things like that. The neurological signs of Lewy body disorder are extrapyramidal features, stiffness, movements, sleep disturbance. You oftentimes see problems with REM sleep disorder, with impairment in ability to get their REM sleep. If they do get to sleep, they oftentimes report vivid, frightening dreams. Okay, let's go to the next slide, I think. Now, this is the recap, because I've talked a lot. So there are many different types of dementia, and I've only talked on a few here. Please understand that when you get someone with a diagnosis of dementia, you need to start thinking about what someone might do on your unit or units. The type of the dementia is important. The size and scope of the involvement, and by involvement I mean where it's located. Is it cortical, subcortical, or mixed? Location, front versus back, right versus left. All of those are crucial in predicting the sort of behaviors that most people with that sort of dementia are going to develop, as well as how your individual may react or respond. The last thing I have on this page is history, which is culture, career, pre-existing mental illness, everything. The very first case I ever was consulted on in a geriatric unit was a gentleman who would come out at night, and he would come to the nurse's station, and then they reported that he was going back and going into everyone's room. Well, I went over and watched him one night, and it turned out that he would, yes, come up to the nurse's station, but that when he turned around, he couldn't recognize which was the door to his room. He couldn't remember which door down the hallway it was. So, the staff said, well, can we put his picture outside the door? And my response was, well, what age does he think he is? Because remember, I don't know if I mentioned, but with Alzheimer's, oftentimes they lose years going backwards. So when they look in the mirror, they want to know who that old person is. If you have an ex-policeman on your unit with dementia, especially right-sided dementia, and he starts trying to put people's hands behind their backs, ask him why he's doing it. We had a gentleman like that as well. He said that he was trying to control the perps, and we had to spend time explaining to him that they were not perps, that they were co-patients.
Okay, so a couple of things. First of all, if you have any questions, please go ahead and enter those questions into chat for Dr. Russell, or any residents' behaviors maybe that you wanted to bring up and ask a question about. Feel free to go ahead and do that. Adelina, thank you. Adelina shared that this was eye-opening, so thank you very much. I think it's helpful to kind of understand, again, just differences between the dementias.
One of the things I always want people to understand whenever I'm asked to consult on the unit is, medications oftentimes are necessary, especially when someone's a danger to self or others. But oftentimes understanding both the dementia and the underlying situation oftentimes gives you what the information you need to change the environment or the way people interact with patients to sometimes ameliorate the behaviors that you're seeing. Now, that being said, I would never, ever want to work on a unit that had just dementia pugilistica and a fire bell goes off.
Dr. Russell, Skitch Ferguson asks, are prescriptions more effective on some versus others?
That's actually a very good question. Have them send me an email, because I'll need to think about that one off the top of my head.
Okay. Skitch, do you see Dr. Russell's email right here in the presentation? So you could go ahead and reach out regarding your question. While we're waiting, I'm going to go ahead and ask Adelina's question, which was, how old do you start noticing a person getting dementia? What is the youngest?
Early, all of the dementias have a category called early onset. I think the earliest onset oftentimes, unfortunately, occurs with those with Huntington's. However, if it's due to repeated blows to the head, if it's due to alcohol, if it's due to substances, if it's due to a massive car accident, oftentimes, it can occur at any age.
Couple more questions. Gilbert said that he echoes Adelina's comment. His perception was it was more of a single origin type, and this adds a larger scope than originally thought.
There are, depending on which book you read, there's 26 to 62 different kinds of dementia.
Kind of boggles the mind. Okay, I think we've got Kathy able to ask her question. Are you there, Kathy? So, Kathy, we are going to actually post the presentation on our website. It usually takes us a couple weeks, about 2 weeks or so, and I'll send out an email.
Thank you.
You're welcome. Okay, a couple more questions. Again, Skitch asks, do any interventions work? Redirection, anticipatory guidance, is it ever psychotherapeutic if used with the age the person thinks they are? And Adelina asks, adding on to that, how about TBI?
In answering the first question, patience is obviously a huge factor. Oftentimes explaining to the, one of the things I do when I go on a unit is oftentimes I work with the staff and I ask them, do you know what their diagnosis is? Especially if there's a comorbid mental illness as well. Because oftentimes you'll find out from the staff that the patient's doing this to upset me, the patient's doing this to piss me off. And no, it's what the patient does. So it's understanding what they're capable of. It's understanding what you need to consistently help them with in a manner that's not condescending. Because remember, we're talking about adults who, for most of their lives, were able to take care of their own needs. And now we're asking, unfortunately, teenagers and people in their 20s to come in and bathe them, to feed them, and do all of these things. The diagnosis of dementia is not a blanket diagnosis. It doesn't mean that you're impaired in everything, most of the time. So finding out what the patient is able to do, the resident patient is able to do, is really crucial, because you do not want to over care for them as well. That causes frustration, it causes irritability, it causes agony. Oftentimes asking them, do you need help with something, more than once, sometimes every day, is the way to go. Dignity is a big word in treating those with dementia. Now, in regards to a TBI, with the TBI, it all depends on where the TBI is. That will tell you what to expect from that individual.
Okay, great. Again, Skitch mentioned he's used spaced repetition with some patients successfully for temporary results until the disease advances further.
Correct, with the understanding that almost all of them are progressive.
Yes. Okay. Any additional questions that we have? Again, I want to thank you for joining us today. Thank Dr. Russell for presenting. That was really interesting and eye-opening, as a number of people have said. And I hope you have a fantastic Friday and rest of your weekend. Thanks for joining us today.